Hi everyone, today we will be discussing peptic ulcers. Peptic ulcers affect people globally with a 5 to 10% risk of development in one's lifetime. We will start by addressing the normal physiological function of the stomach and duodenum before diving into the pathophysiology of peptic ulcers. We will explore the complications of peptic ulcers and symptomatic presentation. We will finish by examining the relevance of peptic ulcers to a paramedic, including diagnosis and treatment. In the stomach, we have parietal cells, which secrete hydrochloric acid to help protein digestion and act as a barrier to pathogens, and epithelial cells, which line the stomach. The hydrochloric acid would be damaging to the epithelial cells and cause self-digestion. However, the stomach and duodenum are protected by a mucus bicarbonate barrier. The mucus aspect of the barrier physically prevents the stomach acid from touching the cells. The bicarbonate aspect of the barrier neutralizes the acid, increasing the pH near epithelial cells. Prostaglandins are chemicals which help to protect our stomachs by increasing mucus and bicarbonate production. Prostaglandin also increases blood flow and promotes epithelial cell repair. In a healthy patient, there is a good balance between the acid and the protective forces. What happens when this goes out of balance? That's when we can develop peptic ulcers. Peptic, meaning stomach, and ulcers, meaning injury to the inner membrane of the gastric tract, can occur in the stomach, known as gastric ulcers, or in the duodenum, known as duodenal ulcers. Duodenal ulcers are 4 times more common than gastric ulcers and more prevalent in men. In a peptic ulcer, after the protective superficial mucosal layer is affected, the inner layers are susceptible to acidity. Therefore, damage usually goes beyond the mucosa and extends to the muscularis mucosa. At this point, the ability of the mucosal cells to secrete bicarbonate is compromised. Gastric and duodenal ulcers have typical sites: the lesser curvature of the stomach for gastric ulcers and the start of the small intestine or the duodenal bulb for duodenal ulcers. The causes of peptic ulcers are all ways in which a person will develop an imbalance of acid and the protective forces. We'll start with the most common cause of peptic ulcers, a Helicobacter pylori infection. H. pylori is a gram-negative bacteria which is usually acquired in childhood and lives in the stomach lining. It begins by weakening the gastric mucosa, allowing acid and pepsin to reach epithelial cells. The infection provokes an immune response that contributes to injury. The bacteria invades the lamina propria, stimulating macrophages and increasing the secretion of inflammatory factors which further aggravate gastromucosal damage. Specifically, macrophages release CCL3, which breaks down the epithelial barrier by disrupting tight junctions, making the gastric lining more vulnerable to injury and ulcers. H. pylori also impairs the secretion of bicarbonate, promoting the development of acidity and gastric metaplasia. The cytokines released by macrophages also affect parietal cell function, causing decreased acid production or even no acid production at all. The next common cause of peptic ulcers is the use of non-steroidal anti-inflammatory drugs. These drugs inhibit the COX-1 enzyme, therefore suppressing prostaglandin synthesis. This reduces the amount of protective gastric mucus and bicarbonate production, hence an imbalance occurs. The use of these drugs also impairs blood flow. Lastly, smoking, stress, and obesity have all been associated with peptic ulcer disease. Let's take a look at some of the complications and consequences of peptic ulcers. We'll start with an upper gastrointestinal hemorrhage. Ulcers can erode into blood vessels in the gastric or duodenal wall. Acid and pepsin digest the vessel wall, causing bleeding that can cause hematemesis or myelina. Next, we'll look at perforation, which can be free or confined. Free perforation occurs when ulcers erode into the peritoneal cavity, usually from the anterior duodenum or stomach, leading to sudden intense epigastric pain spreading across the abdomen and can cause possible shock. In contrast, confined perforation happens when adhesions limit the leak, with gastric contents entering a circumscribed area or adjacent organs. Therefore, intense persistent pain that may be referred often to the back and changed by body position. Now for our rarer complications. First, we have stomach cancer. Patients with H. pylori associated peptic ulcers can experience chronic inflammation, atrophy, and intestinal metaplasia, increasing the risk of stomach cancer. The next rarer complication is a gastric outlet obstruction. Ulcers can cause inflammation, edema, and scarring, causing a gastric outlet obstruction. This narrows the gastric outlet, leading to delayed gastric emptying, vomiting, bloating, and fullness. Next, we'll identify and explain the key signs and symptoms of a peptic ulcer. First of all, we have epigastric abdominal pain. This is caused by stomach acid and pepsin irritating the ulcerated mucosa. Gastric and duodenal ulcers can be differentiated from the timing of their symptoms and pain in relation to meals. For gastric ulcers, symptoms often do not follow a consistent pattern. Sometimes eating will exacerbate instead of relieving the pain. Nocturnal pain is common with duodenal ulcers and tends to be more consistent. Next, we have bloating and abdominal fullness. Due to the delayed gastric emptying or impaired motility from inflammation, a patient may experience bloating. Those with a gastric outlet obstruction commonly report a history of abdomen bloating or fullness. Another symptom is nausea and vomiting due to irritation of the gastric mucosa and inflammation, which can trigger the vomiting reflex. Next, we have weight loss or weight gain. Pain or nausea may reduce food intake, causing weight loss, or inflammation may alter digestion and therefore appetite, which may cause weight changes. As we spoke about before, a patient may experience hematemesis or myelina. So, how is this relevant to a paramedic? Well, understanding the pathophysiology and key signs of peptic ulcers is necessary for paramedics in the pre-hospital setting. Recognition of key symptoms such as epigastric pain, nausea, or myelina allows paramedics to identify potential peptic ulcer disease early and differentiate it from other causes of abdominal pain, such as gastritis, myocardial infarction, or pancreatitis. Alarming features such as severe vomiting, unintentional weight loss, or gastrointestinal bleeding indicate a higher risk of complications, such as perforation or hemorrhage, which require urgent hospital transport. Knowledge of underlying causes, such as the use of NSAID or H. pylori infection, can inform a paramedic's history taking and therefore risk assessment, and aid in better patient education. So, moving on to treatment, pre-hospital management for peptic ulcers is minimal. However, education about the use of drugs to manage peptic ulcers could be delivered. Peptic ulcers can be managed with the use of drugs which limit the secretion of gastric acid, such as H2 receptor antagonists and proton pump inhibitors. This helps to reduce irritation of ulcerated mucosa, relieve symptoms like pain and heartburn, and promote healing of the ulcer. In addition, antibiotics are often used. After endoscopy, surgery may be required if the patient is unresponsive to other treatments or at a high risk of complications. Education about the implications of NSAID use and therefore the recommendation to discontinue use may be beneficial by paramedics. In terms of pre-hospital management, paramedics can prioritize stabilization, including monitoring vital signs, managing shock if there is significant bleeding, and providing analgesia. Clinicians should avoid the use of NSAIDs, including aspirin, as not only is it an NSAID but also an antiplatelet. Early recognition and appropriate treatment is vital for peptic ulcers, so let's move on to diagnosis. A diagnosis pre-hospitally is only provisional. Symptoms of epigastric abdominal pain, early fullness after a meal should raise suspicion of peptic ulcer disease. The pain of gastric ulcers increases 15 to 30 minutes after a meal and may result in weight loss, whereas pain of duodenal ulcers decreases with a meal and usually results in weight gain. Any patient presenting with hematemesis, myelina, anemia, or weight loss should be further investigated for complications of peptic ulcers, predominantly bleeding, perforation, or cancer. A physical exam may reveal epigastric abdominal tenderness. In conclusion, peptic ulcers develop when the protective mechanisms of the stomach and duodenum are outweighed by damaging factors such as H. pylori infection or NSAID use. This imbalance leads to mucosal breakdown, ulcer formation, and potential complications, including bleeding, perforation, obstruction, and even malignancy. Recognizing symptoms such as epigastric pain, bloating, vomiting, or gastrointestinal bleeding allow paramedics to identify possible peptic ulcer disease, prioritize urgent cases, and provide stabilization while ensuring timely hospital transfer for a diagnosis and management.